This is a Bhekisisa podcast.
Any indoor activity, especially those which involve taking of masks, like restaurants, gyms, and so on, those kinds of indoor activities should be restricted to only vaccinated individuals.
Welcome to this podcast. I'm Mia Malan. On Saturday, March 5th, it will be 2 years since the first COVID-19 case in South Africa was officially recorded. So where are we now? Is the pandemic at the stage where it's becoming less serious? And what will happen to things like mask wearing and social distancing? To give us answers, I'm talking to Professor Salim Adbool Karim today. He's the former co-chair of our COVID-19 Ministerial Advisory Committee and also heads up Bhekisisa, the Centre for the AIDS Programme of Research in South Africa. Prof. Karim, thanks very much for joining me today. Where are we at with COVID in South Africa? Is the Omicron wave over?
South Africa started its Omicron fourth wave on the 2nd of December of last year and ended the wave about 2 weeks and a bit ago. So we are well and truly over the Omicron wave. We did, at the tail end of the Omicron wave, we did get a new rise in cases. And so that is part of what has created a bit of confusion. We had a rise in cases because schools opened and a new version of the Omicron variant called BA2 started spreading in South Africa and became dominant in late January. So because we had this sort of second little spike due to BA2, it looked like Omicron was ending and then not ending and then ending. But essentially, Omicron wave has ended in South Africa.
So does that mean that we have now reached a different stage of the pandemic? Is it becoming less severe, or can a new variant make everything go back to the way that it looked like last year?
So one of the things that became clear to us is that we have in South Africa a very cyclical set of waves. These waves are pretty irregular. If you look at the interwave period, in other words, the period between when one wave ends and the new one starts, it's pretty consistent. It's roughly around 3 months. So we have a 3-month interwave period. And it doesn't matter what we do, it seems like, during that period. We get a few little outbreaks, but mostly the epidemic in that time remains at a pretty quiescent point. And we are in that right now. Call it a honeymoon period where cases will be low. But we then have to appreciate that at the end of those 3 months, like we've had with the past 4 waves, we can expect that we will get another wave. Now, we don't know whether we'll get that wave for sure, but it's pretty likely given that after every 3 months of the interwave period, we get a new wave. Now, the new wave would have to be driven by a new variant. So in some ways, it's dependent on a new variant becoming available, because the Omicron virus has spread quite widely in South Africa. And Omicron does pretty well in creating immunity against itself. So if you've had Omicron infection, it'll be hard for Omicron to cause a new infection because your past immunity will protect you from it. And of course, vaccines do as well. So the likely scenario is that we will not see a new wave due to Omicron because you've already got immunity to Omicron. And interestingly, if you've been infected with Omicron, you also have pretty good immunity against Delta. We're not likely to see the next wave coming about because of the Omicron variant or the Delta variant. It will come about because we'll have a new variant. And that variant, we have no idea what it looks like. Right? Just like how we had no idea that Omicron would ever come about or that it would even come to exist, we have no idea what that new variant is going to be.
So if we look at the 3-month honeymoon period in between waves, is it mid-May that we're looking at a fifth wave if it does occur?
So if you look at 94 days, which is the low end of that interwave period, we can expect that if there's going to be a fifth wave, it'll occur at the end of April.
So we now in that honeymoon period that you've mentioned, and you've also mentioned that we don't know what will happen because it depends on what a new variant will look like. So what will happen to things like mask wearing and social distancing? Are we just going to continue with it forever because we don't know what's going to happen, or is now a good time to drop it?
South Africa, being in this kind of situation, is in a good position to ease restrictions. We could ease many of our restrictions and not be at high risk of getting a new wave, but you can't just throw everything out. If you do that, you're just asking for trouble, and you'll just get a whole lot of new infections occurring, and probably be Omicron spreading to the remaining individuals. We have to maintain some restrictions, but they could be restrictions that are different from the ones we've dealt with in the past, in that we really need to focus on three things. The first is on mass gatherings. Indoor mass gatherings remain a major concern because of the way in which the virus can spread that would literally infect hundreds of people very quickly and lead to a new wave very quickly. So you have to have some restrictions on indoor mass gatherings. The second is many of the indoor activities will require masks still, but outdoor activities, masks could quite readily be dropped. Now, the third part of it, in my view, is the really important part, and that is that we've got to use vaccines as a critically important measure going forward. And so any indoor activity, especially those which involve taking off masks, like restaurants, gyms, and so on, those kinds of indoor activities should be restricted to only vaccinated individuals. And that would apply in many settings. It should apply to, for example, universities, in classroom settings, in any congregate setting, in an indoor environment. We should make those restricted to vaccinated individuals. So that combination of requiring vaccines for certain settings, so it's not a vaccine mandate, it's not compulsory, but if you're not vaccinated, you can't participate in that activity. That's your choice. Mask wearing for indoor activities and having restrictions on mass gatherings. For the remaining activities, we could probably omit most of them. For example, the sanitizing of hands when you enter places, that can probably be done away with because the risk of transmission from fomites and hands is much less. And when we're not in a wave, it's really not a big source of infection.
So I want you to explain the science behind this, because if I just look at Bhekisisa's Twitter channel, so many people argue that because vaccines have become less effective in preventing us from getting infected, but they stayed effective in preventing us from getting admitted to hospital or dying of COVID, they argue that the vaccines don't protect you that well against getting infected any longer. And if you have natural infection, then you most likely protected against getting hospitalized. So do vaccines still, in the time of Omicron, make it less likely that you transmit the virus or that you get infected?
Individuals who are vaccinated but still get infected, they have a lower amount of virus, what is called a lower viral load, and that translates into lower infectiousness. Individuals who are vaccinated are infectious for a shorter period than unvaccinated individuals. So when a vaccinated person gets infected, because that's happening, we've seen it all the time, breakthrough infections occur, and quite commonly with Delta and Omicron. But when a vaccinated person is infected, it's very different from a non-vaccinated person who's infected. And the difference is that the person who's vaccinated becomes less infectious. And that's translating into a lower, what we call a secondary attack rate. And there are superb studies now. In fact, the latest issue of the New England Journal of Medicine has a study with almost 150,000 contacts that were tracked and tested. And what they show very clearly is that if the person who is infected has been vaccinated with at least 2 doses of the Pfizer vaccine, that individual has a 68% lower chance of spreading the virus to his or her contacts, especially the household contacts.
So I understand what you're saying. So that if you are vaccinated, the community benefit, if you, for instance, go to an indoor setting like a gym, is that the virus is less likely to spread if there are more vaccinated people. But what about natural infection? Isn't it the same that if Omicron spreads so fast and we all infected and have natural immunity, that we will also have immunity and be less likely to spread it?
So what we have seen is that with natural infection, the antibodies that you get, they start diminishing and waning quite fast. In fact, within 2 to 3 months, the antibody levels from natural infection are quite low. And that might explain why we get new waves, by the way. It might be a contributor to that the natural immunity wanes. And so the population is now at a point where they've got low antibodies and could get a new wave. So we know that natural immunity wanes in that way. Vaccine immunity also wanes, but it wanes at a slower rate. But what we have found is that individuals with what we call hybrid immunity, so these are individuals who've had natural infection and a vaccination, they have the best kind of immunity. They have almost 100-fold higher levels of antibodies, and the antibody waning rate, the rate at which it diminishes, is also much longer. So there's a study that was published 2 weeks ago in the New England Journal of Medicine that compared individuals with past infection with individuals who'd had past infection plus a vaccine. And what they show is that the breakthrough infection rate is much higher in individuals with natural infection. So if you've had natural infection, you need to take a vaccine because the vaccine gives you a protection that's much higher than natural immunity on its own against a new infection. So the message is very clear. The data are very clear. If you've had past infection, you need a vaccine.
I spoke to the health department last week and they said they don't have money to buy new vaccines to vaccinate children between 5 and 11. Is it important that we target this group at this stage in our epidemic, or would it be unwise to invest a lot of money in this group?
Now, why would you want to vaccinate these children? Because the argument is, well, they don't get much in the way of severe disease. Severe disease is quite uncommon in those age groups. Well, vaccines do two things. The first is even that low number of severe infections can be avoided if the children were vaccinated. So you could make an impact on the number of severe infections and hospitalizations. And remember, children get a very severe form of COVID, rarely, but they do. That's called MASI. It's given all kinds of new names as well, but it's quite a severe illness. But the second is that with vaccinations, you reduce the risk of children becoming vectors of the virus, that they then carry it to adults, which we know happens. So vaccinating children has a community benefit, in other words, has a benefit to others and a benefit to themselves.
So now what we can do in South Africa is we can get boosters, and the health department allows us to mix and match. And one of the most common questions on our social media channels is it better to mix and match? Should you do it? And is it different for Pfizer and J&J? So if you had Pfizer first and you want to get boosted with J&J, is that a good idea and as good idea as the other way around if you were vaccinated with J&J and then get boosted with Pfizer? Or is there really not much of a difference if you decide to have the same booster as the vaccine that you got vaccinated with?
The evidence now suggests quite clearly that it's a good idea to mix and match. Now, there's evidence from several studies. Probably the most useful for us was a study done by the NIH, which looked at the Moderna, Pfizer, and the J&J vaccine and looked at all the different sequences in which you could have them. And what they basically showed is that when you mix an mRNA vaccine together with a J&J, which is a vector vaccine, you get a better immune response, especially in the antibody levels. Taking a shot of an mRNA after or before a vector vaccine gives you a broader immune response and gives you higher antibody levels than simply taking the same vaccine twice, especially if you look at our situation in South Africa, where we've had a fair number of people that have taken a J&J vaccine. They would benefit enormously by now taking a Pfizer vaccine as a boost.
We hear scientists talking about second-generation vaccines and that will be the future of vaccines and it would be a better way to go. What are second-generation vaccines and why would they be good to use?
So the first-generation vaccines, which is the ones we are using now, they are, I think, nearly about 20 or so that are licensed across the world. They are based on the original version of the SARS-CoV-2 virus. They are based on the strain that is thought to have originally emanated from Wuhan. So that's the original virus. Over time, we can expect that the virus is mutating and changing itself in different ways, and we will need the next generation of vaccines. And those next generation vaccines will not necessarily be vaccines that are specifically targeting a particular strain or variant of the virus, but rather the next generation vaccines would be vaccines that are designed to be less impacted by mutations. So they are likely to be what we call pan-coronavirus vaccines. They are vaccines designed to protect you from all of the different variants, including variants that haven't even emerged yet. And those vaccines often are targeting the conserved parts of the virus. They target parts of the virus can't change without compromising itself. So that's likely to be the next generation of vaccines that we see. We can expect that the next generation of vaccines will have a much broader immune response and will be able to kill many more different kinds of variants. So we don't end up with the current problem that we have. Every time there's a new variant, we're not sure if vaccines are going to work. We would hope the second generation vaccines would fix that problem.
So with the possibility of vaccines like that, we also hear scientists talking about reaching an epidemic stage of COVID as opposed to a pandemic stage. What is the difference between the two, and are we reaching that stage?
The way in which this virus has been spreading, it certainly, when it spreads in one part of the world, it quite quickly spreads everywhere. And there are very few countries that have been able to keep it out. I mean, even China, which has a zero COVID policy, or New Zealand, that has a zero COVID policy, have had great difficulty keeping Omicron out. So once the virus is spreading as an epidemic in one country, it very quickly becomes pandemic. What we anticipate is that we will, in all likelihood, and we know we don't know this for sure, but in all likelihood, that we will see new variants emerge. Just like how we had Delta and Omicron, we're likely to see a few more new variants, and they will cause widespread infections. Now, the virus cannot continue to evolve to generating new variants that can spread forever. There will come a point where it cannot continue to mutate to get advantage. Now, I don't know when that's going to occur. Is that going to be sooner or later? We don't know. We can expect reasonably it's going to occur sometime within the next 2-3 years. When we get to a point where the variant of the virus is not able to mutate to get significant new advantage, then that variant will become what we can call an endemic variant. In other words, it's now the variant that's going to hang around. It can't be displaced easily because the mutations don't give the virus an advantage to displace it. So when we get to that kind of endemic variant, we will be in a position to make a new set of vaccines that are highly effective against that variant. And so we can expect that we will quite quickly get to a point when the virus is endemic. In other words, it's reached a variant that can't mutate to advantage anymore, that we will get to a point where we won't be concerned about it. Because once you've been vaccinated, it will protect you from that variant. And that's the point at which we will then no longer be concerned about getting new waves of infection. And so we won't worry about it in the same way that we are concerned about SARS-CoV-2 at the moment.
That was Professor Salim Adbool Karim from the Center for the AIDS Program of Research in South Africa. That's it from me, Mia Malan. Keep an eye out for our next Bhekisisa podcast in the next 2 to 3 weeks. Goodbye until next time.
This was a Bhekisisa podcast.